All right, imagine this. You're on call, scrolling through an MRI that was done for headaches, and bam, there it is, a pituitary mass. What do you do next? Well, in this explainer, we're going to build a really practical, step-by-step playbook, especially for medical trainees, on exactly how to tackle these pituitary masses, from the moment you find one all the way to managing it. Okay, let's dive in.
First up, we'll start with that super common scenario of the unexpected finding. Then, we're going to organize our whole evaluation around 3 core clinical questions. Is it causing a mass effect? Is it pumping out too many hormones? And is it causing any hormone deficiencies? And finally, we'll tie it all together into a clear, actionable clinical playbook you can actually use. So let's kick things off with that classic situation, the rise of the pituitary incidentuloma. It's the mass you weren't even looking for, but now that you've found it, it's on your plate to figure out. This is it, right? The fundamental question. And honestly, it can feel a little daunting at first, but trust me, having a systematic approach, which is what we're about to build, makes all the difference in the world. And you are absolutely going to face this question. Why? Because these things are incredibly common. I mean, look at this. Depending on the study, anywhere from 10 to almost 40% of routine MRIs will show an incidental microadenoma. This isn't some rare diagnosis, this is a common player, and you need to know the playbook. Now, the good news, the vast majority of these are benign and they don't secrete any hormones. But, and this is a really crucial point, benign does not mean do nothing. We still need to do a thorough and systematic workup to make sure we're not missing anything important. Okay, this brings us to our very first question. Before we even think about a single hormone lab, we have to think like a real estate agent. It's all about location, location, location. Is this tumor physically compressing its very important neighbors?
And what's really amazing about this image is the anatomy. The pituitary gland, you can see it here with the open arrow. It lives in a really crowded neighborhood. Look how the optic chiasm is sitting right on top of it, and the carotid arteries are boxing it in on both sides. There is just no room for expansion here.
And this crowded real estate has direct consequences. If that tumor grows up, it crushes the optic chiasm, causing that textbook bitemporal hemianopsia, losing your peripheral vision. If it pushes on the normal gland, you start getting hormone deficiencies. And here's a great clinical pearl. If it compresses a pituitary stalk, it can actually block dopamine from doing its job, which causes a mild rise in prolactin. That's a key distinction to remember. Let's move on to our second big question. We've talked about structural problems, so now let's flip the coin and look at functional ones. Is this tumor basically an overactive factory, just churning out way too much of a specific hormone? So here's the bottom line. For any pituitary mass you find, you have to screen for the big 3. These are the functional adenomas that cause major problems systemically. Prolactinomas, growth hormone secreting tumors that cause acromegaly, and ACTH secreting tumors that cause Cushing disease. Figuring out the cause of high prolactin, this is a classic board exam question, and this table right here is basically your cheat sheet. You see, a prolactin between 25 and 100, it could be from meds, could be stock compression, but once you start crossing 100, and especially 200, you should be highly suspicious of a true prolactin-secreting tumor. The level itself is an incredibly powerful diagnostic tool. For acromegaly, the pathway is just as logical. You don't check a random growth hormone level. It's pulsatile, it's all over the place. Instead, you screen with its stable downstream marker, IGF-1. If that's high, you move to confirm with an oral glucose tolerance test. See, a healthy pituitary shuts down GH when you give it sugar. A tumor just keeps on going. And just a quick but really vital point on terminology. Cushing's syndrome is high cortisol from any cause. But Cushing disease is when that high cortisol is specifically being driven by an ACTH-secreting pituitary tumor. Using our words precisely is key. So we've asked about mass effect, and we've asked about hormone overproduction. Our third and final question tackles the exact opposite problem. Is the tumor compressing the normal gland so much that it's starting to fail? This is a fantastic clinical pearl. Not all the cells in the pituitary are created equal when it comes to pressure. The cells making growth hormone and the gonadotropins, that's your LH and FSH, they're the most fragile. That means they are almost always the first to go offline. And this creates a predictable pattern of failure. GH and the gonadotropins go first. TSH and ACTH deficiencies tend to happen later on, but their loss is way more immediately life-threatening. This hierarchy helps you anticipate and screen for the most dangerous problems first. Now, when you're assessing for those two most critical deficiencies, you have to notice the key differences. For adrenal insufficiency, an 8 a.m. cortisol is your go-to test. For secondary hypothyroidism, you need both a TSH and a free T4. And pay really close attention to monitoring. With secondary hypothyroidism, you follow the free T4 because the TSH is no longer a reliable marker of what's going on. Okay, we've asked our 3 core questions. Now let's put it all together into our clinical playbook, a clear, actionable plan for that patient with the incidental menisoma on their MRI report. Here it is, your initial game plan. For any incidentaloma, you need a high-quality, dedicated pituitary MRI. If that tumor is anywhere near the optic chiasm, you get formal visual field testing. Then you run your labs, systematically screening for both hypersecretion and hypopituitarism. You gotta cover all your bases. So, what if your workup reveals a non-functioning adenoma? The hormone labs are all totally normal. What's the trigger? When do you pick up the phone and call a neurosurgeon? The indications are actually very clear, and they all pretty much revolve around one thing: vision. Any confirmed visual field deficit is an indication for a referral. Even with normal vision, if the tumor is clearly compressed in the chiasm on the MRI, that's an indication. And of course, pituitary apoplexy. That's sudden bleed into the tumor, that's a neurosurgical emergency. And what if surgery isn't needed? Well, then you're in surveillance mode. But there's a protocol for that too. You re-image the bigger macroadenomas sooner, at 6 months. Microadenomas can wait a year. And if the tumor stays stable after a few years of annual scans, you can start to space out the follow-up. So we'll leave you with this. The next time you see that MRI report, you won't feel lost. You'll have this framework. You'll know the 3 critical questions you need to ask to build your workup and your management plan, turning a moment of uncertainty into confident, systematic, clinical action.